that look like your living room rather than a doctor's clinic. And they talk about compounding hormones, adjusting levels based on your blood level results, and they talk about tailoring therapy for you. And when there is talk like that, it's very easy for a lay person to be attracted to this idea of balancing their hormones. But the wellness promise is not a promise at all. For one thing, there is no such thing as balancing hormones. There is either therapy for something that you need or not. And the other danger is that they do a blood test, they measure hormones, but they don't correlate with the menstrual cycle. There is no method or understanding how these levels are interpreted. So if you take a day 5 serum progesterone, it's going to be low. And that's normal for that part of the cycle. But a wellness doctor will say, oh, we need to increase your progesterone and start on some creams, which can actually be dangerous. The other danger is that compounding pharmacies operate with no regulation. They're not subject to the same quality control as pharmaceutical companies, and we cannot be sure that the prescription is accurate. That means we're not even sure if what is on the label is what is in the bottle. And so you can see how this can be quite dangerous. And although we have some guidance about estrogen and progesterone in the menopause, unfortunately there are a lot of other hormones where there is no guidance at all, and testosterone is one of them. Now we know that testosterone has a lot of importance for a woman. There is enhancing libido, promoting muscle development, energy, red cells. It improves memory, makes your skin better, makes sex better. We know all of these things. But there is no guidance on how to prescribe testosterone. So clinicians for decades have been giving women testosterone for various symptoms with really uncertain risks and benefits. Now, let's stick to the facts. We know that testosterone is an important female hormone. Women either make testosterone directly from the ovaries, or they make the precursor, which is DHEA and DHEA sulfate, which is then converted to testosterone in the tissue. So 2 ways of testosterone reaching the end organ. Now, we also know that testosterone declines with age and menopause. Actually, even from the age of 25 to 50, there is a 25% reduction in women's serum testosterone levels. And it continues to go down after that with a sort of plateau up to about 70, 80. Now, how do we know that someone doesn't have enough testosterone? Can we measure for testosterone deficiency? Now, the problem with that is testosterone is incredibly difficult to measure in women. For one thing, there is variable protein binding with sex hormone binding globulin, albumin, and cortisol binding globulin. So what is actually active is very difficult to determine. The other problem is that there are syntheses from precursors like DHEA and androstenedione, and in the target tissues, testosterone is active. But this is not something we measure in the blood. So blood levels does not equal tissue levels, does not equal the action at the end organ. And we always used to think that free testosterone was active testosterone. But now what we are understanding is that it may not be biologically active testosterone at all. It may actually be a byproduct of testosterone metabolism. Which means, how will we know? Levels of women are also very low compared to men. And when you do tests that are tailored for male levels, whenever you have very high or very low, you know it's going to be inaccurate. So at the levels where women are operating on, these levels are very unpredictable. And there is also cross-reactivity with some progestogens. And no levels to indicate what is deficient. Does that mean we don't measure at all? No, in fact, you should measure. Not free testosterone, but total testosterone before starting any kinds of therapy. Why? Well, actually for a reason that might be surprising to you. It's not to look for deficiency, but actually to identify unexpectedly high levels. So these women may have a different pathology that needs to be treated. And you might want to assess for over-treatment once starting therapy, because women are, after all, giving this treatment to themselves. So why would we want to start testosterone? Now, where evidence is concerned, there is only one indication. That is hypoactive sexual desire disorder. Now, there are lots of different reasons for female sexual dysfunction, but hypoactive sexual desire disorder is when a woman is unable to have any spontaneous thoughts of sex, unable to initiate sex, unable to respond to stimulation, and unable to orgasm. And all of this together, this is important, makes her very distressed. So she's very upset that she cannot do any of these things. Now, if a woman is not interested in sex and she's happy, then that's not a problem at all. But if all of these things are making her upset, then she may have hypoactive sexual desire disorder. But female sexual dysfunction is also quite complex. You may not like to have sex with this person, and that doesn't mean that you have the disorder. I cannot make you like your husband if you don't like him. But so you really need to assess carefully who fits in this category. And this is the only indication for starting testosterone in women. So until 2019, there was no consensus. And so the International Menopause Society decided to bring a group of experts, look through all of the evidence that is out there for testosterone in women, and the guidance that comes from this statement is based on findings from blinded placebo RCTs, at least 12-week duration of testosterone therapy, for which this data is available for meta-analysis. And all the findings are reported with levels of evidence and grades of recommendation. You can look for this online, and it's very clearly stated. And since this consensus statement came out, all these different organizations are now using this as guidance for testosterone therapy. So what does it say? They do say that postmenopausal women with hypoactive sexual desire disorder should be treated with transdermal testosterone in the female physiological dosage. Now, these are all very important words. All the evidence, there is grade A evidence that shows improvement in sexual function, in increasing the events of sexual desire, arousal, orgasmic function, pleasure, and sexual responsiveness compared to a placebo. Testosterone can be used with or without concurrent estrogen therapy. So even if a woman is not taking estrogen, progesterone, or the conventional menopausal hormone therapy, but this is her predominant symptom, you can start testosterone and see whether she improves with it. However, no evidence to treat pre-menopausal women with sexual dysfunction.
Có gì không?
Is testosterone safe? Well, it's a hormone that the female body makes. If it is prescribed in physiological doses for women, it is safe. However, there are no long-term studies, and actually there's no evidence for more than 2 years to say what testosterone does for women. But the current evidence shows no change in blood pressure, lipid profiles, renal or liver function, changes in red cell indices if used in a physiological dose. There may be some side effects like acne and increased hair growth at the application site, but the things women worry about, like alopecia, deepening of the voice, hirsutism, is not there if kept at the physiological dose. If any of these effects occur, then you should monitor for an overdose. So how is testosterone prescribed? Now, the guidance says it should be prescribed as a transdermal preparation in the female physiological dose. And actually, the female physiological dose is 5 grams per day. There is only one company that makes testosterone in the female dose, and that's right at the bottom, the Androfem cream by Lawley Pharma in Australia, only available in Australia. But everywhere else in the world, it is either you import Androfem, or what the guidance says is that you can use a male formulation in a titrated dose. So what's available in Vietnam and in Malaysia, it's the same, is Androgel that's been prepared by Bazan's Healthcare. It is a 50 gram sachet of 1% testosterone. And so what you would do is give a 5 gram per day. So you use the entire 50 gram sachet, but it lasts for 10 days. Because you've got to remember, just because you're giving 50 grams, it doesn't mean that the woman gets 50 grams straight away. There's only about a 9 to 14% absorption. It stabilizes over the next few weeks. And so with all of the various protein binding, you will get a physiological dose as long as you prescribe it like that. Testosterone as oral, pellets or injections cannot be recommended for women, and compounded treatment cannot be recommended because there is no evidence of safety. So how do women use it? Best after a shower, because we know moist skin absorbs the gel best, so clean it. You want to put it in a place where you're not going to be touching other people. So most people put it in the upper arm, lower abdomen, inner thigh. Avoid the hands because you may be also having children or other people that you touch, and they might get your testosterone. Wait for complete absorption. Now, if you're worried like in Malaysia and Vietnam where it's very hot and they're sweating during the day, you can think about nighttime application. How long should treatment last? Like I said, it doesn't go straight into the system. So it should be at least 3 to 6 months to monitor for effectiveness. If it hasn't worked after 6 months, it is unlikely to help and should be stopped. If it is effective, it can be continued for as long as a woman needs it. Monitor every 6 months to make sure there's no overdose, because there's a chance she might just want to use it more, considering all the benefits she's getting from it. Now, what about all the other benefits? We know testosterone does all these great other things. Reduce insulin resistance, better bone strength, improve muscle tone. But the consensus statement says there is not enough evidence to use testosterone to improve cognitive decline in postmenopausal women, to improve general well-being or to treat anxiety or depression, to improve bone mineral density at the spine, hip or femoral neck, because there seems to be, with current evidence, no change in 12 months, to increase lean body mass, muscle strength, or reduce total body fat, which is what we think we're going to achieve with it, and to prevent breast cancer. Now, that is not to say that testosterone doesn't do all of these things. We are just saying there is not enough evidence today to prescribe testosterone for this. So what we really need is more well-designed studies to look at these different outcomes. What about other androgenic preparations? Well, systemic DHEA has not been found to be effective in improving libido or sexual function in postmenopausal women who have a normal adrenal function. And vaginal DHEA has not been tested in those with vulvovaginal atrophy and cannot be used to treat the same thing. So in summary, we need to carefully evaluate and make the diagnosis of HSDD. And you might need to identify other reasons that can cause this low desire. It is not diagnosed by a blood test, and treatment is in female physiological levels. If the formulation is not available, then use the male dosage that is titrated, but do not use compound formulas. Testosterone can be used with or without estrogen-progesterone concurrent therapy. And as I said, more studies are needed to assess the effect of testosterone on all the other aspects of women's health. Thank you very much.